mistake, because imagine some people resect only this part, okay? They resect only the inferior part. Some people resect the whole of this part. Please understand that you're seeing this patient intra-op, that is during the surgery. But after the surgery, you don't know how the healing is going to take place. And if there is fibrosis here, this part of the middle turbinate will be pulled laterally. And what happens is that this part of the middle turbinate covers the frontal recess. And so most of the frontal recess procedures, that is the frontal sinusitis, are in fact due to the covering of this middle turbinate, partial middle turbinate over the frontal recess. So I prefer that you don't touch it. Okay, well, answering your question, if the middle turbinate is not there, the best next landmark will be the inferior turbinate and the maxillary sinus. So once you get the maxillary sinus, the next step is this is the ethmomaxillary, this is called the ethmomaxillary crest. This is the next best landmark, because that gives a lot of block. So that gives a lot of information about the sphenoid sinus. See, I will tell you a lot of mathematics in FES. It's all mathematics. It follows the rule mostly. In most of the cases, it follows the rule. So number one, inferior turbinate. Above the inferior turbinate, you have the maxillary sinus. And that's the maxillary line. That's a beautiful landmark. You can't come anterior to it because the nasolacrimal duct is there. Now, above the maxilla, you have the ethmomaxillary crest, and this is the lamina papyracia. And you follow the lamina papyracia, it'll take you on to the posterior ethmoid and the orbital apex. So you see how beautifully you can actually navigate yourself very, very, very nicely. Now, there are various approaches to approach the sphenoid sinus. I'm going to show you some of the approaches. There are three different approaches. One is called the lateral approach to the sphenoid sinus, where we go, like Professor Stamberger has described in his book, posterior, inferior, medial, and then go inside the sphenoid sinus. I think I generally don't follow that approach. I will tell you what approach I follow. Now, give me a Blexley. See, that's a scavenger forceps being used. Whenever you use it, be very careful. Don't pull. You should take only the bone out. I'm super gentle in this. If I pull that, that mucosa will come out. So that is how it's like, a tiger catching its cub, not injuring it. That's the simile I give. And that mucosa should never, never, ever be resected. Now I'm going to demonstrate how I open the sphenoid sinus to for the beginners. For the beginners, how do I open the sphenoid sinus? Now give me a ball probe. This is what I call as the baby walk. Baby walk. What is the baby walk? So I'm just going. These are all the things I teach in most of the congresses in India, outside India. This is how it easily goes into your brain. So it's very easy to remember this. So how do I open the sphenoid sinus? So sometimes what happens is some people are a little scared to open it from the posterior ethmoid going postero-infero-medial. So I use a ball probe. See here. See here. Now that's the base of the bulla with the junction of the basal lamella. So I slide like this is a baby. One, tuck, tuck. The baby is walking. The baby is walking. And the baby fell down. This is a baby walk, fell down. So where did it fall down? It fell down into the superior meatus. Now what I do is I move it like this. See, I move it like this. So that's the baby walk, baby walk, baby walk, tuck, it fell down. And then I move it like this. If I move it like this, what do I get? I get the superior turbinate. So that's it. So you have an access onto the superior turbinate. So once you have the superior turbinate in your view, you see that, that's the superior turbinate in your view, beautifully seen superior turbinate. You can actually go through the natural ostium of the superior, of the sphenoid sinus. You see here how I do that? See here. That's the superior turbinate, a polypodal superior turbinate. You can resect a small part of it. Don't go and resect the upper part of the superior turbinate because it contacts, it has olfactory fibers. So don't do that. So I'm just resecting a small bit of that superior turbinate, leaving behind most of it. And at what level do you find the sphenoid sinus? This is where your ethmomaxillary crest comes into view. Draw a line from the ethmomaxillary crest, and below that line will be the sphenoid sinus. You can see very beautifully. I'm going to draw a line here, and you can see that. Yeah, so I have a small technique. Again, I will show you the technique. All for juniors. Give me the pack. See here. In fact, we have published one paper. I think Professor Sinia from Russia has published my paper on how to dissect the ethmoid with a small lint. So that's a non-traumatic way. I think that publication, I think, is out, or I'm not sure. She's writing a paper. I'm not sure about that. I trained her in Russia. So here we are. I've kept that gauze piece in the superior meatal window. It's called the superior meatal window. And I have a small probe. This is the made in India probe. You can see that's called the sphenoid probe. It's a malleable probe. And I'm going to use that probe. See here. This is a malleable probe. And you see here, I use it and then I palpate. It'll go inside the sphenoid sinus. So that is the ethmomaxillary crest. And you can actually go there and it'll go inside. See the bubble coming out. That is the bubble sign of Stamberger. Can you see the bubbles coming out, please? Hello?
Yes.
Yeah, yes, we can.
Yes.
If you have a bubble, that's a bubble sign of Stamberger, as described beautifully by our sweet professor. Suction, suction. So I'm going to see that. I've kept that probe in the sphenoid sinus. And that's the superior turbinate. Between the superior turbinate and the septum, I place that probe. So this is a atraumatic probe. It's a malleable probe. Now what I will do, I will use my Blakeslee forceps. See here, I do what is called the reverse technique. See, I go inside and I open it like this. I open it like this. And then like this. So both ways you can open it. So that's a reverse technique. So I don't pluck anything. It's like something like a balloon, maybe. You can compare it with a balloon. So that is actually the reverse technique. I open up the sphenoid sinus. And now I'm going to widen that sphenoid sinus. Give me the debrider. So you can use the debrider safely in the anterior wall of the sphenoid sinus. Don't use
Dr.
it.
Jankiram, as you mentioned, debrider, there is an interesting question from Dr. Vijay.
Yeah.
He's asking if you are operating in a resource-compromised sector and you do not have debriders, what are the alternatives?
My dear, who is the name? What is the name of the?
Dr. Vijay.
I just want to tell you that, will you operate on a mastoid without a drill? I mean, it's like that. It's the same. Nowadays, debrider, if you don't have and you do FES, in fact, I will not do a FES without a debrider.
Okay.
I will just say thank you very much. I will not operate in the case. Because you're going to take off the mucosa. And the whole idea of FES is functional. Functional means mucosal preservation. And no instrument in the world has been designed to preserve the mucosa like the debrider. So I believe that you should not operate. I'm sorry to answer this in a very rude way, but then the only alternative is to use through biting instruments. See here, I'm just going to show you some example. If I pull this, you know what will happen? The mucosa will come out. Am I right, Professor Ashok?
Mm-hmm.
Yes, I mean, that's a very clear answer that if you're operating and it is important to make sure that you got all the appropriate right technology available for the best outcomes.
Okay, if you want to compromise on outcomes, of course, you don't need a good camera. You don't need a good debrider. You can just do it. But if you want good outcomes, if you're a good surgeon, you have to invest on certain equipments which give you good results for your patients. Okay,
correct.
So
and that's
now,
what we have witnessed in rhinology, that all our advances that happen over the last 20, 25 years are quite related to technology. And because of this technology, we have been able to explore further frontiers. So technology is the key. Yeah.
Dr. Ashok, we always say medicine grows by physics.
Mm-hmm.
Absolutely. Yeah, that's very well said. So that's the sphenoid.
You see here, that's very important. What I did was, see here, what I did, I got the planum here. So I got the planum here. And now what I will do, see what I did? That's the maxilla. This is the lamina papyracea. That's the sphenoid sinus. The middle turbinate nicely stable, preserved. And the little bit of the superior turbinate perfectly preserved. And from here, I come reverse. I get the skull base, and you see why I do it, what is called the beggar's movement. The beggar, how does the beggar come? With your hand like this, like this, like this. See that? Exactly like that I come. That's called the all these are terms which, I teach my residents. Never go very harsh on the skull base. Very, 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 very important point. And very important is many people, they leave behind stalactites and stalagmites during fest. I want a smooth looking cavity. Or else I think you have not done a fest properly. This is my contention of the surgery. See that? That's the skull base. That's the skull base. And now what I will do is I will start with my, see, I know the anterior ethmoidal artery is here and it's dehiscent. So, and there might be the middle ethmoidal artery as I read in the scan. So now I will change to 70-degree telescope. Some people operate with a 70-degree telescope throughout their procedure, 30-degree or whatever. I believe that don't use angle telescopes unless you are an expert or you want to do something very funny. To me, I think the best would be a normal vision with a 0-degree telescope. If the situation demands, then use the angle telescope. For example,
Yeah.
I'm sorry. Yeah, please.
I was just going to say you can lose orientation very quickly with the angled telescopes if you're not used to using them.
Absolutely. I fully agree with you. Now, what are the endoscopes which I use during endoscopic sinus surgery? The first endoscope I use is a 0 and the second is a 70. That's it. I don't use any other scope. I don't use 30. I don't use 45. And I'm almost about to complete the surgery, Bala. I think you have to start.
That's perfect. That's a great timing because Prof. Castelnuovo is nearly ready. So once Dr. Jankiram finishes soon, we'll be joining Varese in Italy. Prof. Castelnuovo is performing esthesioneuroblastoma. So we'll be switching between the sites at key stages of the surgery.
Give me a RAD60 debrider blade. So you can see here what I did was I used my 70-degree telescope. I visualized the upper part of the Uncinate process. And you can see here, I'm going to hug the nasofrontal beak. Okay, you can see here, that is, give me a good wash. I am already almost there. I'm going to just wash it here. So again, please understand, don't get misled by the interfrontal cell. So you might have two openings. Right. One is the interfrontal, and you can have the frontal sinus as well. See the polyp coming out of the. Can you see that, please?
Yes. Yeah.
You can see
give me a RAD60, please. Now, there are two things which I want to mention here. This is called instrument above. So I teach my residents, there are two techniques of frontal. One is instrument above and second is instrument below. And here what I'm doing is instrument above. You can see here that's the cell, maybe the interfrontal cell, not the frontal sinus. Give me a small lint. So now I'm going to open up. This is the most important part of the surgery. I think, can the audience stay with me or you want to shift to Castelnuovo, Professor?
Okay, you can complete this probably.
Because this is the last 5 minutes, 5 or 10 minutes of the surgery.
Perfect. Yeah, we'll stay.
Give me a J
we'll let you finish in 5 minutes. Yeah, perfect. So to our delegates who are asking questions, yes, we will take your questions. And thank you for your interest in the surgeries.
You can see here that this is something which I love to do. Keep adrenaline soaked gauze piece, but not very, very, don't press it very hard because that's going to damage again the mucosa. Now give me a maxillary sinus suction tip. So I think I'm gone into the, see that? That's beautiful. Wonderful now. Now, what I will
Right.
do now is take that giraffe, please. Giraffe. Side to side giraffe. So you should always have two giraffes. One is side to side giraffe and anteroposterior giraffe. And always do it under vision. This is very, very important. You have to do it under vision. You cannot do it. Okay, right. Now let me have a look at what I'm seeing right now. You can see that very beautifully. A cell has been opened. Now what I will do is, I know that if that is a cell, then that means you will find the frontal recess behind that cell. So these are all mathematics. That's it. These are all mathematics. I'm going to take off the cell above. Give me the debrider, please, quick. I got the frontal now. That's the frontal now. Now I'm going to use my debrider. So I got the interfrontal cell. I knew that the frontal was pushed laterally. So that's very important. See, all this should run in your mind. This is all anatomy. You don't need a navigation to do this. Again, instrument. So you can see that the frontal, can you see that or not? Give me a wash.
Yes,
Yes,
yes.
I will open it. You can use a frontal mushroom as well. See the pus coming out of the frontal.
yes, yeah, that's brilliant.
So this is like, when you keep it there, it should be there. That is reading anatomy. You cannot just, group around. That is not the way you read a scan. I tell my residents, you should be pretty sure about what you're doing. See that? That's the frontal very
Yes.
beautifully seen there. And that's not enough. That's not enough, because I've not seen all the four boundaries of the frontal recess. So what I'm going to do is now to widen this frontal recess. Okay, that's the frontal, I know. The interfrontal cell has been opened, I know. So move your debrider gently posteriorly to open up the suprabular cell. Go closer now. You will be seeing the anterior ethmoidal artery now. A little.
And is this one of the angled microdebriders, the RAD 60 or?
RAD 60. This is
or-
RAD
yeah.
60. Can you recognize the structure?
That's an excellent view. And I think back to the question earlier about instruments, if you have the correct microdebrider, you can then add so many disposable ends to it and really make it very multifunctional. Drills and the angled micro, RAD 90, RAD 60, etc.
Yep. Give me yeah, that's right. So that's a RAD 60 debrider blade. And you have the RAD 122 if you want to.
Mm-hmm.
So the most important thing here is to irrigate inside the frontal sinus. Because, the crevices of the frontal sinus might be hosting a lot of pus bacteria. You don't want that to happen. So and more important is the postoperative, steroid wash. And that has to reach the frontal. So you can see here see the wide frontal recess. Can you all see that there's a small polyp out there?
Yes.
Yeah. So what
Yes,
do?
yeah.
You have to irrigate. You have to irrigate. The most important thing is irrigate. That's the single most important carry home message I want to give. When you do frontal recess surgery, don't hesitate to irrigate a lot. Once you irrigate, most of that will just come out.
And do you have
Okay.
steroid impregnated in the rinse that you're using currently?
What?
Or is that just saline at the moment?
Yeah. You're right. I sometimes use the steroids also. So I'm going to now show you how I'm going to give me the debrider. I'm going to take off that polyp. It's still there. Not happy about that polyp hiding there. So I'm going to use my debrider here and instrument above. Of course, I can't see that area because it's an angled. Okay, not bad. Give me irrigation again. So if you have a polyp like that, what do you do? So what I do is I keep one Merocil or a lint soaked in steroid inside the frontal. Give me a small lint soaked in steroid. Decadron. So I use a steroid, that is a Decadron, and I soak it there. Can you all appreciate it, please?
Yes.
Now what I will do is I'll just push this steroid soaked lint inside the frontal. Give me a J-curate. And I hope that that polyp will regress. That's it. I can't go and operate inside the frontal sinus. That is not the idea.
How long do you
I-
keep this, or it just
I keep it for a
stays there?
minute. I keep it for a minute.
Okay.
Before that, I just try to, delineate the anterior model artery. I'm going to delineate the anterior model artery now. See, basically in frontal recess surgery, the most important thing is to see all the 4 boundaries of the frontal recess. Again and again, I say the boundaries of the frontal recess are the most important things to see. Give me the debrider. What are the boundaries? Medially, middle turbinate. Laterally, lamina papyracea. Posteriorly will be the anterior model artery. Wait. Don't get too much. You can see the skull base is completely delineated. Can you all appreciate it, please?
Yes, correct. Yeah, to the mucosa preservation.
And
This-
this area only little mucosa is gone, but other areas, you can see that's the anterior model artery, very beautifully seen. This is the fovea, and that's the frontal recess. You can see how nicely the frontal is seen there. Very beautifully
Mhm.
seen. Now
Correct.
give
I
me
think that-
irrigation.
So that's a
Upfront.
fantastic demonstration, Dr. Jankiram, and yours.
Just a
uh,
minute. I am yet
yeah.
to finish. Just a minute. I will just tell how I'm going to do the last part of the surgery. I'm sorry. You can see here, that's the frontal. There's a little polyp again. Give me a good irrigation. Give me steroid washes. Steroid washes. I hope with aeration, with budesonide washes, this polypoidal change will go off. Post-op, we'll be managing the frontal. And so the last part of the surgery, always remember the olfactory cleft. Don't forget the olfactory cleft, because sometimes, not in all cases, the olfaction is gone because of mechanical obstruction of the olfactory cleft with polyposis. Give me straight debrider. So see that this can actually cause a mechanical obstruction. See the sphenoid sinus, so beautifully seen.
Yeah.
This is the sphenoid, the skull base, the anterior model artery is here. I'm going to show you. I'm going to remove that. Give me a debrider. I don't want even a single stalactite. That's very, 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 very important. Now I'm going for the olfactory cleft. And when you do the olfactory cleft, don't debride on both sides, because again, you will lead to fibrosis. So I debride only on one side.
That's fantastic. That's an excellent clearance of all the polyposis on the right side. So what you have witnessed here is the technique, safe technique, establishing the landmarks, and thoroughness with attention to preservation of the mucosa and a good hemostasis, with the clearance of all the sinuses, the maxillary sinus, the anterior posterior ethmoid, the sphenoid, and the frontal sinus, and finally clearance of the olfactory cleft, being careful not causing any adhesions there, which will cause any hyposmia. So thank you, Dr.
Thank you very
Jankiram.
much,
Okay,
Professor Ashok.
and we will join you again. We look forward to stay with you throughout the day with various different surgeries. We'll ask the appropriate questions at the time, and we will now be joining Verise in Italy. Prof. Paolo Castronovo is nearly ready to start the surgery, and he's got a very interesting case of esthesioneuroblastoma, which is involving the skull base. So over to Verise in Italy, and we'll join Prof. Castronovo. So thank you, Professor. It's an absolute privilege to have you demonstrating this surgery to our global delegates. You have been a part of GRN right at its inset on every live surgical event. He has demonstrated wonderful surgeries. So without further ado, over to you, Prof. Paolo.
Hi, thank you for invitation. And now Dr. Pistocchini will present to you the clinical case of this lady with olfactory neuroblastoma, and then we start immediately the surgery.
Thank you.
Please, Andrea.
Okay, hi Ashok, can you hear?
Yes, Mario, hi. Yes, I can hear you.
Okay. So as Professor Castronovo said, she's a woman, she's 48 years old. In 2016, she has sinonasal surgery in Ukraine for chronic rhinosinusitis with nasal polyps. But in 2022, she had a right respiratory nasal obstruction relapse, and the ENT evaluation suspected a right nasal fossa inverted papilloma. So always in Ukraine, she underwent endoscopic sinus surgery, but the histological examination was esthesioneuroblastoma, EMS2, with doubtful radicality. So she came to Italy, and then she had a revision of the histologic evaluation in Naples that confirmed the esthesioneuroblastoma. So she came to our hospital, and again, she had the ENT evaluation, maxillofacial MR and CT scan, and total body CT scan, which showed N0, M0. At the CT scan, you can appreciate the previous surgery with the removal of the middle turbinate, with the opening of a little anterior ethmoid, and posteriorly, at level of the posterior third of the olfactory cleft, you can appreciate there is this residual, which we have studied at the MR. You see at the MR, this is the contrast enhanced MR. At level of the posterior third of the olfactory cleft, this is this enhanced neoformation with a little contrast enhancement also at the dura of the olfactory cleft. The olfactory bulb does not seem affected, but has to be checked by histological examination. So the program for the surgery, as we said, is a monolateral right endoscopic resection of the olfactory neuroblastoma with the transnasal craniectomy and skull-base reconstruction with fascia lata and septal mucosal flap. We have to decide if we will use a flip flap of the contralateral septal mucosa and the higher part of the contralateral adult flap. So now we can see the surgery.
So now I show you the right nasal fossa, inferior turbinate, and now eustachian tube,
Can you see Ashok?
Yes, yeah, we can see the
tail of
indiscriminate.
middle turbinate,
And
which is
thank
the
you, Andrea.
predecessor. The tail of superior, a tail of supreme turbinate there, and the natural ostium of sphenoid. And again, this is the uncinate process, the bulla, and this is the residual tumor in the olfactory groove, in the olfactory fossa. This is uncinate process and bulla. So the program is the resection of the tumor with a centripetal resection. We start to mark the border of the resection with the diode laser.
Professor, what technology are you using for this surgery?
So I'm using now a 0-degree scope and the incision of the mucoperiosteum I will perform with a diode laser. It's a contact laser.
That's interesting. So does that help with giving a bloodless film? Do you use any navigation for this surgery?
Okay, this is the position.
No, we'll not use navigation for this surgery. It's quite
There's
limited.
no navigation. Okay.
We don't.
Dammi il 45 gradi. Now I change the scope. I take the 45-degree scope for the superior incision of the mucoperiosteum. Dammi ancora il laser. So the 45-degree scope, and this is the anterior incision with the laser. No. Non riesco a... No, questo, quello da frontale mi devi dare. Allora, dammi...
If you didn't have access to the laser, could
Dammi
you
il
use
beaver.
the needle tip monopolar for this marking out?
Yes, we can use the cold instrument like the Weaver. Yes, we can use also the monopolar like the Colorado.
Mm-hmm.
Let me... Here I am taking the superior plane it's quite difficult to reach. Oh, non riesco, troppo stretto. Deve darmi un sistema di lavaggio perché non riesco a fare niente qui. Com'è la pressione? Perché non ci siamo, ragazzi. Non... Dammi lo 0. No, lo scolatore. So the criteria, the techniques is to find the superior steel plane and to make the dissection. No. Dammi la forbice. I take the plane on the lacrimal pathways. Sì, se no non riesco a fare niente. Adesso è un po' presto. Dammi il J-Curette. Lava. I'm taking the plane on the uncinate, and then I look for the elevation of the mucoperiosteum at the level of papyraceae. Dammi la 1 piccola, tagliente. Allora, aspiratore, scolatore, e poi dammi ancora la... Ok, so... Dammi il basket. I enlarge the middle antrostomy to control the posterior edge of the fontanella area. Brava. C'è quello curvo? Laser. Guarda che è rotto. Tirami fuori la punta. So now with the dart laser, I make the the border of the Coana and the Fontanella area. Okay.
So is there a plan to send any frozen sections today during the surgery?
Non ho capito. Yes, of course. We have the pathologist with us in the OR,
Okay.
and we send generally 10, 15 frozen sections during the surgery
Okay.
to be sure that the resection will be in free margin resection.
Do you
M'hai
ever
trovato
find
quello
that you
curvo?
have to convert to a full craniofacial resection when the initial plan has been a unilateral?
Sorry, can you repeat?
Have you ever been in the situation where you've had to convert to a full bilateral craniofacial resection based on your frozen sections or what you found intraoperatively?
No, we never have this situation. We sometimes with the frozen section, we have enlarged our resection, but we never experienced the change of the procedure from endonasal to combined or external procedure. Usually, up to now, all the cases we perform, the external procedure was scheduled since the beginning. But of course, never say never. Hai quello più grosso? Lo scollatore è quello un po' più grosso.
So, Professor, there is a question that what is the definitive treatment plan? Is it just the surgery, or is there going to be further therapy like a radiotherapy or a chemotherapy for this patient?
Well, of course, it depends on the extension of the disease.
Okay.
If the tumor is not in contact with the dura, dammi lo thread tagliente, we can perform only surgery, but if we have contact with the dura, the radiotherapy is mandatory. And if there is contact with the dura, we know that the radiotherapy has to involve the neck and the retropharyngeal node.
Okay. Thank you.
So there is some bleeding, and what I am doing now is to make a centripetal resection. Dammi ancora la 1 tagliente. This is the papyresia. I'm elevating the mucoperiosteum of, you see, the posterior wall of the maxillary sinus.
Yes.
And now ethmoid. The criteria, the oncologic criteria is completely different comparing the surgical procedure for inflammatory, for FES, because in this case, I keep, mi dai il trapano? The ethmoid, I don't enter in the ethmoid, I don't violate the ethmoid, but I make the superosteal resection. Lava, 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 lava. Lava, sta sanguinando ancora parecchio, non riesce a diminuire. Tieni qua, sono a bagno di sangue io. Parlate piano. Aspira. Giusy, io ho il microfono, parlate piano.
I think I just seen Dr. Jankiram operating on a nasal polyps and how conservative he was on the nasal and the sinus mucosa. However, this is a different pathology, and this pathology dictates that the mucosa is cleared of the disease. So it's a very different approach to the sinus mucosa, where the mucosa is actually stripped of the sinus cavities.
So now with the bipolar forceps, I coagulate the sphenopalatine turbinate branches, right? This is sphenopalatine turbinate branches, and behind the septal branches. Dammi una velina 2. Lava. So this is the roof. You see optic nerve
Mhm.
Yes.
This is the optic nerve.
Yes.
So we reach the posterior edge. Okay, and this is a sphenoid. So this is the optic nerve in Onodi cell. You see, this is the floor of the Onodi, the lateral OCR, the floor of the Onodi, and the sphenoid. Now we have to cut the artery, the sphenopalatine septal branch, this one, ancora bipolare. See. Okay, so bipolar. Dammi la 1 tagliente. Tagli così. Now we cut the septal branches of sphenopalatine, and we make free. Steady.
Is this
Lava.
a 4 millimeter diamond burr that
Lava.
you're using?
I am drilling the connection between posterior ethmoid and sphenoid. There was a lot of blood, unluckily. Ok, tieni qua. Oh, cazzo. Riesci a... This is the floor of the Onodi. Aspira, vieni un po' indietro. Vieni via. Okay. So I try to show you what we have done. Maxillary sinus, papiresia, Onodi cell, optic nerve, lateral OCR, carotid, sphenoid.
That's excellent.
Now we take a part of the mucosa of the sphenoid to have the frozen section in the sphenoid. So we give the mucosa of the lateral wall of the sphenoid to have a frozen section of the free margin posteriorly. You see the clivus there, lava, the vertical carotid. Sì.
So, Professor, if you just give a detailed sphenoid view to our delegates, and then we'll take a very brief break, join to DCR Professor Jankiram for 10 minutes, and then come back to you further. Okay. So, could we have some sphenoid, a good view of the sphenoid landmarks, please?
So, yes, this is clivus. This is the vertical carotid artery. This is the floor of the onodi. This is the optic nerve, lateral OCR. Optic nerve,
great.
lateral OCR, floor of onodi, clivus, sella floor, vertical carotid.
Thank you. I think that's excellent.
Pleasure.
And I think see the difference between the surgical techniques, how we strip the whole mucosa. So we saw two wonderful techniques of mucosal preservation in polyp surgery, while in tumor surgery, how we excise the mucosa along with the periosteum over the bony landmarks. So thank you. So over to Trichy, where Professor Jankiram is
Prova a darmi la
demonstrating
45.
So the studio, shall we get over to
Il
Trichy,
problema
please?
è riuscire adesso a fare la parte sopra, perché non ho spazio.
Possiamo mettere in muto il microfono del Pro?
Hello, can you join to Trichy, please? Dr. Jankiram?
Hello, can you hear me, sir?
Yes, we can hear you. Yes.
Okay, so
Okay.
this is a case of a DCR, which is going to be done on the left side in a lady. I didn't present the case, but this technique has been published by us in the British Journal of Otolaryngology, JLO, and this is a flap which has been designed by me and elevator. So you can see that this is an inferiorly based flap. It's not a posteriorly based flap. You can see here very clearly that this is an inferiorly based flap, and you can see that this is the middle turbinate. That's the axilla. I go around 6 millimeters above the axilla because the fundus of the sac is far above the axilla. So you see that I'm now trying to elevate that flap. So, and this small area of mucosa is what I'm going to resect. So basically in a DCR, there are two important things I always say. One is mucosa should cover the bone completely. If it doesn't cover, then you will have a problem of fibrosis. So that is the first step. See that. See how nicely the flap has come down. No, don't do anything. That is the flap which has come down. So that's the first flap. Then give me a Blexley now. So you can see the ascending process of maxilla very beautifully here. This is the ascending process of maxilla. Can you all clearly see that, please?
Yes. Very clear.
Yes.
Thank you.
Now I'm going to remove that small piece of mucosa out. So that's where the sac is going to be there. And the next is, give me a, elevator. So I'm going to elevate a flap posteriorly. See, inferiorly, I have raised this flap. Then I'm going to raise a flap here. See that? This is a medialized uncinate process. And I'm rising that flap posteriorly. So these are the two flaps which I always rise when I do a DCR. Are you able to get me, please? Dr. Ashok, please.
Oh, yeah. Yes. Yeah. So we see
So
you clearly.
that is
We're going to
a
see you again
second
the
flap
flaps.
which I'm rising. So that is a flap which I have now raised posteriorly. I'll tell you why I'm rising these two flaps. I have a very important statement for this. Of course, you can see the article which we have published. And okay. Now, after this, I use my punch forceps. So this will take around 10 minutes. Only DCR will take only 10 minutes for me. You can see that. Yeah, upturn. So I'm going to start with my punch forceps and I go just above that flap and I engage it. See that? That is the first bite I take. Now, but I am not now at the level of the sac. I am at the level of the duct. Please
Mhm.
understand, I am at the level of the duct, not at the level of the sac. Now, see that? Now I have removed that. Can you all appreciate it, please? The duct.
Yes. Yeah, we can
Yes.
see the
Now,
duct
what
very
you do,
clearly.
see, the
Thank you.
movement is very important. See here, this movement, you go like this, you keep it like this, and then don't punch. Hold it and twist. Hold it and twist. Hold it and twist. See what happens now. See that? See that? Can you see that?
Yes.
You
What
can
happened?
break it.
The whole bone came out. It's just a matter of around, 2 minutes. Completely the whole bone came out. So that's how I always, give me a small lint. So you see, I've almost exposed the sac, but it's not enough. The commonest cause for failure in DCR is poor exposure of the sac. This is, of the bone. If you don't expose the bone properly, then you will land up with failures. I never use a stent in DCR. I never use a stent in DCR. Give me a punch quickly. So just 3-4 punches and it's done. That's it. See here. Okay. See, what is the difference? How will you know it's the sac, it's the duct? You will see the dilatation. Give me a small lint, adrenaline soaked lint, please. Yeah. See, it is done under local anesthesia. This is done under local anesthesia. It's a very small procedure, very, very small procedure. You can see now how nicely the, press the sac, my dear friend. See that, that's the sac.
Mhm.
Can you see? Satya is pressing the
Yes.
sac.
Yes.
Now
Yes,
I have
correct.
to go up. I have to go up. Don't stop short here. That is the commonest mistake many people do, because we have to expose the common canaliculus. See again, see that, see that movement. Can you see the movement? Very, very important
Yes.
movement. See, many people, they actually punch, or some people use the drill. Drill produces a lot of heat, and that can, again, don't use lasers, don't use a lot of heat producing instruments, coblation. I use only the cold steel instrument, and that's it. And we have finished the bone exposure in a couple of minutes. I finished it. That's it. And now what I will do is I'm now going to pack it properly, and you can see the sac. All of you, can you see that sac, please? All of you.
Yes,
Is
we
it
can see the
beautifully
Yes.
seen?
sac on allotment. Yeah, correct. Yeah. Do you use
Now-
what degree endoscope do you use, Dr. Jankira?
Everything is
it,
zero. Everything
zero
zero,
degree.
zero,
Okay.
zero, zero, zero.
Okay.
Now, the last step, AC. It's like the brain stem. I call the sac like the brain stem. Brain stem, if you look at it from the ventral aspect, you have, give me a ball probe. You have a convexity, right? You have a convexity. The same way you have to see the sac. You see here, you have a convexity here. You see the anterior end of the convexity. This is the posterior end of the convexity. Can you see that? So your
Yes.
exposure should be both the anterior and the posterior end of the convexity. And this is periosteum. It's not the sac, it's the periosteum. The periorbita continues like this as the periosteum. Give me another punch. I want one more punch. So this is where we made a lot of studies, and I published it. So many people, what they do is at this moment, they make a incision of the sac. I don't make an incision, because if you incise along with the periosteum, give me a pack, then there's a chance of recurrence again. So give me a sickle knife. I'm going to take a few minutes, and then you can go back to your original, professor's video. Just 2 minutes. This is a very important part, very, very important part, which we did a lot of study on. See here, press, my dear friend. Press, my dear friend. See here. Now, give me a sickle knife. Now, this sickle knife I use, see here. What I do now is, see here. See here, that is the endosteal layer.
Yes.
So we have 2 layers covering the sac. One is the endosteal layer, and second is the endothelial layer. And between that, you will have a venous plexus. Ma kasam se daslam kya?
Do you use any lacrimal probing at this stage?
Can you
help
see the
us with
venous
the-
plexus, please?
Yeah, we can. Yeah. Do you
So
do this
that
with
we-
the probing?
What?
Do you do any lacrimal
No, no,
probing
no,
at
no,
this
no,
stage?
no. Why probing? Probing is done only when you're not sure about whether this is a sac or not. This is actually a clear-cut sac. There's no doubt. You can see beautifully the venous plexus. Very beautiful. Can you see the venous plexus very clearly there? And
Yes,
I
yes.
am, and give me the probing. I never do the probing unless, you know, I'm maybe revisions. Wait. Give me this one. No, sickle knife. I'm just going to remove that endosteal layer completely, because I don't see, if you leave behind the endosteal layer, we found 2 or 3% patients come with recurrence. And sometimes it's actually very thick. This layer is very thick in some patients, and it actually leads to problems. Now see here, now I'm removing that layer completely. So I'm going up, I'm removing that layer again. See how this is like a corneal dissection. I always call this a corneal dissection. Now comes the opening of the sac. Now I will be opening it. How do I open it? I don't just like that cut open. You have a lumen, you have a medial wall, you have a lateral wall. Okay, give me a small lint again. Give me a lint again. Small lint. Just stay with me for 2 minutes. I am through. Would you like to have the CSF leak after this? Because shall I ask my anesthetist to intubate?
You can
I'm going to
start preparing for that. If you
Yeah,
want to take a mini break,
fluorescent. We
that'll
are
be
planning
fine.
for fluorescent for that case. Fluorescent.
Yeah,
It's a case
that
of
will take some
BIH.
time.
It's a
Yeah,
case of
that will take-
BIH.
Okay, that'll be interesting. And if you're injecting fluorescein, so you'll need some time for it to work. So
Yeah. So
that'll
we
be
will not
fine.
intubate now. You tell me when to intubate and then we will do it. Okay, this case was intubated 45 minutes before. Okay, give me the knife. Now, you see what I do? This is the most important part of the surgery. Now, I'm going to use my knife. No, you don't have a 11 blade. See here, I use my knife now, 11 blade. Okay, make that incision like this. See here, gently incise. You will find pus for sure. Okay, give me a ball probe now. Press it. Now, the most important thing is not to injure the lateral wall of the sac. So still I have not opened up the sac. See how thick this because of inflammation. So I'm trying to enter into the lumen. Give me a 11 blade knife, please. So very important that this is because of inflammation that the endothelial layer is very thick. So that is a very, very important point you should remember. Give me 11 blade knife, please. I'm going to open up the sac. Quick, ma. Yeah, thank you. Now this patient is going to, yeah. See that? Can you see that, please?
Yes, sir.
Yes.
Great accuracy.
Suction. Now, what
Excellent,
you
yeah.
do is you don't try to open it more. So what I'm going to do is to use my ball probe now. You see what I do. This is very, very important. And you create 2 flaps. You see here, I go into the lumen. I open it like this, and I open it downwards. Right. Now, after that, I use my Kassam scissors. The Kassam scissors, the skull-based scissors. Suction. I use a Kassam scissors. Give me a Kassam scissors. See here, I create 2 flaps now. I create a posteriorly based flap and an anteriorly based flap. See here, that's the scissors. Press. Okay, that's the first cut. The beauty of the scissors is it's rotatable scissors. I can cut both ways. Suction. So what I do, you have 2 flaps now. One is a posteriorly based flap here. Can you see that? That's a posteriorly based flap. Can you all appreciate it?
Yes. Yeah. Yes.
Give me an
that's right.
acoustic knife. Acoustic knife, please. Acoustic knife. Quick. Acoustic knife. This is an acoustic knife which I use to make the anterior flap. You can see that. Now what happens is that you have two flaps, one anterior and one posterior. Now that posterior flap is where that uncinate is going to sit over that flap, and the anterior flap. Wow, can you syringe it now? Now I'm going to show you the common canaliculus. That's very important. Wait, suction. I'll show them the common canaliculus. So the common canaliculus, you should see the common canaliculus. Or else, wait, Satya. No, come on. Now I'm going to ask Satya to. Okay, ready? Wait, now. Inject. Can you see that, my dear friends?
Yes.
Yes,
yes.
That's
That's excellent.
antibiotic. That's antibiotic solution.
Okay.
See how nicely you can see that fundus of the sac, beautifully open. And now I'm just going to close. See how many minutes did we take? It's around 15 minutes, maybe, or maybe even less. So this is how we do the DCR, absolutely atraumatic. And that bone is covered with, we don't pack this nose. Give me the ointment. Give.
So there's no
We-
pack at all.
No pack. See, there's no bleeding, there's no
fantastic.
pack. Local anesthesia. Give me this one. Ball pro,
This
please.
is under local anesthesia during the surgery.
There's no, we don't pack it at all. You don't need to pack it. You see here, this goes and covers the, hey, give me, there's a small gauze piece over there. Flexly, please. Can you see how the bone has been covered?
Yes, that's great. So what antibiotic flush was used? Which antibiotic? was
Wait,
it?
I'm going to show you that antibiotic. Give me that. Chloromycin.
Okay, thank you.
See that. Just a minute. See, that's the lumen which I've opened, and that will go over this. This flap comes and covers this. So we have two mucosal flaps which are being covered. That's the lumen. There is no raw bone exposed. Now see what I do now. See what I do. No Surgicel, no gel foam, just this ointment. Finish. Thank you very much.
Okay, thank you, Dr. Jankiram. And we'll be back to you when you're with your CSF leak. So
Yeah.
the next case for Dr. Jankiram is endoscopic closure of a CSF leak. They're going to inject the fluorescein when the patient's getting ready. So in the meantime, we'll join back to Professor Castronovo in Varese, Italy, where he's dealing with aspicial neuroblastoma, which is involving the skull base. So join back to Professor Castronovo. Thank you. Hello, Prof. So we're back with you.
Dammi bipolare. Okay.
So can you please update us
Bipolar.
on, steps that were done in between?